Before we begin, please take a moment to review the disclaimer in the episode description. Remember, this podcast is for informational purposes only and is not a substitute for medical advice. Now let's get started. Welcome to Wound Basics, the podcast that does exactly what it says on the tin, helps people to understand the basics of wound care. I'm Dr. Frances Henshaw, and my guest today is Anne-Marie Dunk, and in this episode we'll be talking about a very important topic: how to differentiate between incontinence-associated dermatitis and pressure injuries. Hi, Anne-Marie.
Hi, Fran. Thank you for inviting me.
It's a pleasure to have you here because today's subject is something that I know that you know quite a lot about, quite a lot more than me, but that's not difficult. So let's start by talking about the topic. So today we're going to be talking about incontinence-associated dermatitis and pressure injuries. And these are two things that are often confused with each other. Let's start by defining pressure injuries and incontinence-associated dermatitis. What are they and how do they differ?
Well, yes, it's one of my favourite topics, pressure injuries and preventing pressure injuries especially. And all these etiologies actually have a wonderful definition which helps you understand or leads you to allude to why they occur. So pressure injury is a localised damage to the skin or the underlying tissue as a result of pressure or pressure in combination with a shear. Pressure injuries usually occur over bony prominences, and they may also be related to a medical device or another object. And that is the new definition that came out in the 2019 guidelines. And so there are very key things in that allude to why a pressure injury might occur.
That's really quite succinct, isn't it? It's got all the bits and pieces in it.
Absolutely. And another thing you might know a pressure injury may be called in the past, historically, is pressure ulcer, bed sore, pressure areas, or decubitus ulcer, which is still a term used overseas. But in our region in Australia, we are using the term pressure injury.
Oh, thanks for clarifying that. And now incontinence-associated dermatitis. Can you define that one for us, please?
Yep. Incontinence-associated dermatitis is an irritant contact dermatitis. That means it's an inflammation of the skin, and it's found exclusively in patients that have urine or fecal incontinence. So that also helps you clarify and determine what's going on at skin level. So if they have fecal or urinary incontinence, you might be seeing incontinence-associated dermatitis in difference to seeing a pressure injury. However, they can live together.
So this is kind of the nub of the problem, I think. They get confused, don't they? So how can healthcare workers differentiate between incontinence-associated dermatitis and pressure injuries when they're assessing a lesion?
Well, they're both found down in the pelvic region, but remember, pressure injuries can be found over bony surfaces, so they can be found in the occipital area and at the heel area, and they're not places where you see incontinence of urine or fecal matter. So we've actually have a really great differentiation table that I'll share with you that helps us to work through what we're seeing. So when you think about the cause with pressure injuries, it's the pressure and the shear forces. With incontinence-associated dermatitis, it's the moisture at the skin surface, and it's the friction that might come at skin level. The location is over bony prominences, like I mentioned, for pressure injuries, but with incontinence-associated dermatitis, you'll find it at the perianal or the anal cleft. The shape is different when you're looking at something. A pressure injury is very circular and it looks like a spot. But when you're looking at incontinence, it's very diffused, and what skin damage you might see on one buttock cheek, you will actually see on the other. The depth for a pressure injury is superficial at times, right down to being very deep. We know that pressure injuries can go right down to the muscle and the deeper anatomy. However, with IAD, you'll only see that at a very superficial skin loss. You won't see it very much past the dermis level. Necrosis is possible with pressure injuries because we have a staging classification that identifies that. And necrosis is dead tissue at skin surface. When you rarely see that with incontinence-associated dermatitis. The edges of the wound or the lesions are very different. They're distinct edges with pressure injuries, but incontinence-associated dermatitis shows that they're very diffused, irregular edges. The colour is red and it's equal with pressure injuries. However, the redness is not equal with incontinence-associated dermatitis.
So there's quite a lot of different differentiating factors. And you mentioned that there was a table that really quite nicely illustrates this. Obviously, we can't see a table on a podcast, but could you tell our listeners where they might be able to find said table?
Yes. If you look somewhere in the literature and you look for Dimitri Beekman's work, you'll find there's a lot of publications around the differentiation between IAD and pressure injuries as part of his key work.
Excellent, because obviously the treatment pathways would be quite different. Now, we're not going to get into the nuts and bolts of treatment, but it's very important to know what you're looking at, because otherwise you might go down the wrong path on trying to manage something.
Absolutely, Fran. And the other thing that's available to us as clinicians are the different differentiation classification tools for both. There's one for pressure injuries, which you can find in the literature, and the International Pressure Injury Guides talks about 6 classifications of pressure injuries. And we're also in some health facilities really looking at how medical devices or devices can actually cause pressure injuries as well, and to be aware of that. And then with the incontinence-associated dermatitis, we have the Globiad tool, which is 4 categories of determining the severity of IAD.
Right. So basically there's guidelines that identify incontinence-associated dermatitis and pressure injuries, both these types of lesions, and there is also resources that will help you to differentiate between both of them. So we've got all of this covered by the looks of things. You mentioned that one of the obvious risk factors for incontinence-associated dermatitis is incontinence. And obviously, if the person that you're examining is not incontinent and they've got a lesion, you can pretty much rule that out straight away. But what are the other specific risk factors that predispose people to developing IAD or pressure injuries?
Well, it's the moisture at the skin surface. IAD is considered moisture-associated skin damage, and that's the umbrella that it sort of presents itself under. But the key determinants of identifying it is the fecal or urine incontinence at the skin surface. And a lot of the enzymes that come out of the bowel in the fecal fluids will actually start to break down the cellular structure at skin surface and cause lots of problems there. So working really hard, if you've got a patient that actually needs incontinence pads, or you would have to think that you need to put some structures in to prevent by doing cleaning and preventative strategies. With pressure injuries, you can also have turning regimes, keeping that patient moving, not allowing those areas with bony structures to actually have high pressure loads at different times. There's many things we can do to prevent these injuries from occurring.
Absolutely. And if you know what you're dealing with, then the guidelines can tell you very clearly how to deal with it. And obviously a lot of people who might be listening to this podcast, it might not be in their remit to actually try and fix these things. It's more important that they recognise them and escalate them at the right time. And if you're not certain what it is, because sometimes it can be difficult to be certain, especially if you've not seen these things many times before, then it's a good time to get an extra pair of eyes out, I would imagine.
Absolutely, Fran. And just asking if a patient has pain over a bony surface, you actually will get a lot of information. And then, the next thing is to do a skin assessment in that space. The other thing with IAD, it actually causes a lot of pain. It exposes a lot of the nerve endings that just sit under the skin, and a lot of patients that who've had IAD will tell you that it's excruciatingly painful.
Yeah, I've heard that actually, and it looks very, very angry, doesn't it? Yeah. So before we conclude, do you have any final tips or recommendations for healthcare workers when they're seeing IAD and pressure injuries?
I think IAD prevention is better than managing.
So you basically need to be on high alert for people who are incontinent, because prevention strategies in that group of people will pay dividends.
And like you mentioned, persons in the aged care setting often have difficulty communicating what's going on. And so therefore you could assume that anyone is at high risk of IAD development if they are incontinent of urine or fecal matter. With pressure injuries, any patient that actually cannot independently, or person that cannot independently move, you have to consider that they could be at risk of pressure injury development. So there's two key things to look out for, and as the classification staging identifies that you can get some really life-threatening skin and tissue damage by not putting appropriate strategies in place.
Absolutely. And I think the overarching thing that I see that runs through this is related to frailty and people losing their robustness. And so when people do age and they become more frail, they're very much more susceptible. And it's really up to us to be the detectives who can actually figure out what's going on with somebody. And, we've talked previously about skin assessment. So I think this is where your skin assessment comes in really handy, because you may find, for example, a stage 1 pressure injury that if you hadn't done the skin assessment at that time, maybe a stage 2 or 3 by the time you find it. And the same with Incontinence-Associated Dermatitis. I think when, there's a sign of a moisture injury, you've got time to act before it becomes catastrophic. Anne-Marie, I'm really glad that we had this chat today, because I have to say, being a podiatrist by trade, I don't know much about incontinence-associated dermatitis, but now I think I'd at least have a fighting chance of distinguishing it from a pressure injury. So thanks very much.
Thanks, Fran.
Thanks for listening to Wound Basics. This show was brought to you by Smith & Nephew, shaping what's possible in wound care.